Hey, what's up, everybody? You're here at the pilot episode of Pillosophy. I'm Max Lyles, Senior Director at the Counseling Center, and I'm joined today by Program Coordinator Whitney Folsom.
Hello.
What's going on, Whitney?
I'm here.
We are too. So first, let's get started with just some introduction kind of things. Tell us a little bit about some of the stuff that you've done with the agency and in the field.
So to scroll all the way back to when I first started within the agency,
Sure.
I began as an intern way back in undergrad at Shawnee State University.
Go Bears.
I was placed there by Dr. Ronnie Rader, and she had put me in stepping stones where I just fell in love with the program and the mission and just being within that field, and I knew then that that's what I wanted to do. So after my internship, I took a job at Kroger, was like slice and deli meat, and just
it did
not really ideal.
So your job at Kroger did not have the same impactful meaning in your life as your job within the behavioral health field?
Yeah, no.
Wasn't
I
feeling
can't have deli meat ever again. So, so I took a little hiatus, and then I ended up applying for a job, and it was for a transporter at Stepping Stones where I did my internship.
Shout out to the transportation department.
Yeah.
Closing their loop on probably their 3,000th trip this month or something like that. I think the mileage from February was that they went around the world twice.
Yeah.
Literally.
No doubt.
Literally.
So I had that experience first, and that was, following my internship, that was a pretty wild, really crucial piece. I feel like everyone needs to start, or at least be exposed to, every level of care in that sense. And so being a transporter, you really learn fast that people talk a lot in vehicles, and they open up and they're vulnerable, and you just see a totally different side of people. And and so that was really great, and I have a lot of fun memories.
And that was post graduation from Shawnee?
I believe I was still in school.
Okay.
So I was finishing up, and I did that for maybe 6 months, and then a case management position opened up within Stepping Stones, and it just kind of rolled on out from there.
Yeah. So you went from van case management to office case management, right? And so then from there, you've been in the field for some years at this point. So talk about some of that experience you've had, like within the field and the different programs and things, agencies that you've worked for.
Sure. And a lot of those experiences within other programs, it's pretty interesting to get a sense of what each program provides to clients. And through this agency and through other agencies that I've worked for as well, and how that has impacted so many people on different levels,
right?
And that access to care, and just seeing people at every step of the way, right? So I feel very grateful in working in different programs and being able to see people in just various phases of their care and treatment. Because
thinking out loud here, so you've got the Stepping Stones internship experience, the transportation experience, which I can echo that. Being able to start, like, my first job in the field in housing is just like a totally different vibe than anything else, like clinical wise, that you do, right? But then also, so at this point, check box on Stepping Stones, check the box on transportation. Then you've also worked in outpatient programs. Mm-hmm. You've also worked in partial hospitalization programs with supportive housing, crisis center setting, mental health counselor setting, and now management, right, of multiple kind of programs, right? So in short, Whitney street cred's pretty high, right? You got some, you're like an actual, you're a real life professional, my dude. You know what I'm saying?
Well, thank you.
Yeah. Any other thing we've left out as far as like program experience or like agency experience or field experience that you feel like's been important for you?
I think one of the biggest differences and contrasts that I've seen within this agency is going from like a residential program to outpatient. And I think that there's a lot of missing pieces for people that don't experience that outpatient setting, because it's just vastly different. And so I think that is a piece that is really crucial. And I think the outpatient program here does a great job at just meeting people where they're at and not having, just being welcoming and, not having more of like the structure and like requirements that are in place for other programs. And so I think that experience in itself is just really, that's been the most interesting piece, I think.
Yeah, see all the different sides of that thing. Yeah, and it's one of those of too is like, there's it takes like all the pieces of the pie to make it work, and we'll get into some of that stuff as far as, program offerings and continuums of care and that kind of stuff first. One of the first things we wanted to address topic wise was kind of like the current market and the way that some of the things that we see within behavioral health care, and we see trends locally that a lot of agencies have started to pop up in the last 4 years, but that's also not unique to our area. I think a lot of people think that it is, that what we're experiencing here is somehow an anomaly, but it's also like in the state of Ohio seen a big boom in behavioral health treatment, and then also in the nation. I feel targeted by Zuck and the gang because of the ads that pop up are treatment agency ads, and I'm gang affiliated, so I get it, but then I'll look and it's an agency in Florida or California or whatever. So I think to talk about that boom and how that happened, and maybe how, despite our perception is that it's just here, talk about like how, from your perspective, how did all that happen? What was the lead in for those kind of things?
So I remember, and I was in the field when the Medicaid expansion happened.
Thanks, Obama.
Yes. And that in itself really opened up the door for people to get care that otherwise could not before that. So I think, and I just remember it was mostly like women with children that could access treatment and care. And then suddenly like the Medicaid expansion opened that up to where, a lot more men had access to care that they didn't have before that. So that boom happened right and around that time. So I'm not really sure what year that was, but
I think Affordable Health Care Act, again, shout out to Pres Barack Obama for getting that done. But then also I believe it was Kasich, the Republican governor at the time in Ohio, adopting Medicaid expansion in the state of Ohio, because access to care was what was good for Ohioans at that point in time. So you see some like bipartisan partnership there, but we're probably talking around the 2012 mark, right? So we start to see like more people being able to get in just in like volume, then a more diverse population being able to get in, not just women or women with children, but also like, I know the big one was single men being able to access like state funded insurance was a huge thing with that. And then from Medicaid expansion sort of opening up the door for access, and then at a few years later, the state steps in and starts to talk about modernizing the reimbursement system in the state of Ohio, modernizing the levels of care in the state of Ohio, kind of getting us up to speed with the rest of the country in regards to people who are having good outcomes. When do you remember the first time you ever heard about the behavioral health redesign?
Oh, it was terrifying.
Yeah, it was like the boogeyman, right? It was like the boogeyman. So talk about a little bit like, how did that idea get introduced to you? Because I'm assuming at the time you were just like me, just a provider. Yeah. Talk a little bit about that.
I think whenever that was introduced to programs and teams, it was just this really daunting thing, because it seemed really arcane at the time. Like, and no one really knew what that meant, but they just knew it was like a bad word. No one really knew what direction it was going to go, and like how that was going to change how we care for people. And so I think there was a lot of trial and error and just trying to figure out. I just remember trying to figure out what exactly certain things meant. And other people being very confused with that.
And even leadership, not just like other providers, but like the highest ranking, like licensed people, the highest ranking administrative people being like, kind of shrugging their shoulders like, well, I don't know, we just kind of jump off the cliff and try to survive the fall, right? It's like, see what happens. So I remember hearing about it. And some of the people who were mentors, who were supervisors, who were people that I looked up to in the sort of helping field community, being terrified that this was going to be somehow the death of behavioral health treatment as we knew it, that the small scale agencies like would not survive. Right. Yeah. You remember some of those conversations as well?
Yeah, and I think that it was right in line with that boom. And so, it wasn't just on like an agency standpoint either. It was just in general. It's like, how are all these people going to get the care? Because it was already overwhelming and just it was too much to kind of handle at that point. Yeah. So then with that redesign, it became, a fear of like, well, who's going to be able to have access to care, and like, how long is that going to be for each individual? Because then and it's all a blur for me. So I've kind of like repressed that a little bit.
Repress those terrible memories of the trying times.
And I also, I was probably doing like case management when that came out. So I didn't really have to have my hands in that and try and navigate that from that angle. But I just remember some of the fears of like, well, if this person comes into treatment, like how long are they going to be able to stay in treatment? What are like the limitations of that?
Even some limitations around the frequency at which a person can come to treatment if they are not adhering to the treatment. Like, for example, I come into treatment, I complete, say, a program, I leave said program and then have a return to use, that I might not be able to re-access the care. Yeah. I know that was like a huge thing that people were worried about at that point in time. Yeah. Yeah.
So I don't know.
Yeah, there were like frameworks and rules and policies that were in around that kind of stuff. Yeah. Yeah. And I think some of that was, attempting to address opportunities for access for people who maybe hadn't been able to get in the game, and of course, a lot of this as well, like we're able now to discuss in like hindsight, and even though it's a blur and we've repressed, these terrible memories of like, this is going to be bad, right? Like, it's kind of, it's wild to like look back for me and see how far the field's like come and changed and those kind of things, right? I think though is like a lot of the fear was that how are we all going to survive this? How's everybody going to get paid? How's everybody going to get access to care? From my perspective, none of that came to fruition.
Yeah.
Isn't that wild?
Hollow fears, and I know they were for good reason at the time.
Yeah, sure. We were concerned about longevity of the agencies to provide care for the people that would then be the client longevity.
Yeah, it was just this big unknown, and looking back on those things now, it's like, oh, that never did happen. So
well, and actually, and then kind of brings us into our next point, like with the current market and things, it's the opposite kind of happened, right? So then in the last 4 years since the behavioral health redesign, I think there was a lot of fear that agencies were going to be shutting their doors, people weren't going to be able to get paid, clients weren't going to be able to access care, but we've actually seen the opposite. Yeah. We've seen like a huge influx of people opening behavioral health care centers and those kind of things. Right. Talk about how that's like, how maybe that's been influenced or how that's affected like local access and the client population and those kind of things.
I think that the access for treatment has been so overwhelming, and that need is so high that, those contenders and those people that are coming in to offer more access to care is very necessary. And I think that there was a point, after the redesign had kind of simmered a bit, where
we're going to figure, we started to adopt the idea that, hey, we're going to figure this thing out.
Right. I think locally we had seen more people come in and, set up shop, and a lot of those places are very valuable to the community. Sure. And have really set up important programs within the community as well. And as we know, we live in a capitalist society, so there are always people that come in and see how profitable that can be.
Right.
And we've definitely seen our fair share of that as well.
Sure.
So.
Yeah. And then that kind of leads into, you brought up the access thing, and it's like, a lot of times the question gets asked, do we need all of these places? And an easy argument for that is like, well, look at the number of overdose deaths that are happening. Like you're talking about, the Russian-Ukrainian conflict very much at the forefront of like national news media, right? And of course, there are effects of that, but it's like on the home front, it's like 100,000 people died last year from a drug overdose, and you don't hear a lot about it, right? So it's like our priorities of what we kind of pay our mind to, right? I think is maybe not so much of what we should or what's really pertinent to us, because when you think about, like if you from 2000 to now, you're talking over 1 million people who are dead. It's more than all. It is more than all wars that have been fought if you take out the Civil War, like a higher body count. And in a 20-year span, it's like it seems like it's such a daunting, such like a big, pervasive, chronic problem, but then doesn't necessarily get attention that other things do in pop culture.
Right.
You know?
Yeah, and I mean, I think that's just a societal thing in itself where, those things kind of pop up on the radar a bit, and they become really hot topics, and then they just kind of fizzle back out, and then they come back up, and regardless of where that's at within society and the community and who's talking about it, like the problem is still here. And especially people that are working within this field, I think we're all just really tired.
Yeah, absolutely.
And it's just been an ongoing thing, and we see the severity of it continuing. So it's a lot bigger than I think what we can even really sit back and process.
Well, it's hard to wrap your mind around those kind of numbers. You know what I mean? So it's then like from an access point, it's like the state has two major initiatives, one being access, right? And it's like the other one being the quality of the services that happen. But at this point, it's like the problem is so invasive, it's so persistent, it's so chronic. It's like we probably haven't even caught up from an access point to be able to then like put our full attention towards what the quality of those kind of things are, right?
Yeah, and I know that the limit is just having, the goal is to have the structured care, and like, and eventually get to a point to where it's preventative. But I think everyone within the field sees that, we're just kind of bobbing our head up.
And then getting dunked back underwater,
And
we do get a breath of air every now and then.
Yeah, every once in a while.
Every once in a while you get a breath of air and you think, hey, I feel good about this. And it's like we're right back under the water.
Exactly. So, prevention would always be the most important piece, but I think that we're just taking it as it comes and having to deal with it in that way. So.
And I think like with the increased access and talking about, local perception and the way that stuff is seen here, we've started to see recently some like local political initiative to try to on their own accord address like whatever the quality metrics are that they want, or talk about how treatment should happen or what treatment should look like and those kinds of things, right? What are some of the things that you've seen locally that have been happening for people to start to address where treatment can happen, what treatment can look like, what the standard of care should be, and then kind of your 2 cents about that?
What I have seen is a lot of disconnect within the local political movement to just kind of shift this over into, like, this is where we can go. These are the limitations. This is what needs to happen. And just kind of dictating treatment in general for the community. And, Portsmouth is a really unique place in that front because there are not very many areas, even within the state of Ohio, that really serve such a continuum level of care on that front. And so what tends to happen is that the community itself is this huge recovery community.
Right. You see that in the anonymous fellowships. You see that with some of the church population.
Yeah.
You see that in the presence of the recovery, treatment centered agencies that exist here. Yeah.
Yeah. So I think that while the intentions may be good, locally, I think there is a plan to enact some zoning laws.
Sure.
Where treatment facilities can only provide housing. You can correct me if I'm off the mark, but to just enforce treatment facilities to provide care in certain specific areas in the community. So it's kind of like this out of sight, out of mind. Great that this is happening, that you're getting help, but we just don't really want to see that. And my own fear is that it is going into this goal of separation within the community, and that's not my goal. That's not our goal as an agency, I think. And the goal for us is integration, to break down some of those stigmas and to just have people understand that all of these things and all of these reasons why they don't want like a sober living house on their street is maybe a little biased, and maybe not really seeing the person for who they are.
And I think you see it with some of the things that we're attempting to be addressed in the update of the zoning. And I'll also say Portsmouth hasn't been rezoned since World War II era. Like, the city probably does need updated in regards to zoning and our future goals, right? I don't think that the rezoning of the city is should be used as an opportunity to dictate what treatment should look like and then what housing should look like past what's already in the state law.
Right.
There's already fire safety code things. There are already landlord laws. And then also as well, if people are dissatisfied with the quality of treatment at the city level, at the county level, at the state level, they already have the ability to complain to the bodies that oversee treatment anyways.
Right.
Ohio Mental Health and Addiction Services, Medicaid, their local councilmen, your local congressmen, senators, those kind of things. Like, you already have the ability to complain about that.
Right.
Right. It's to me, it seems like two things that necessarily historically haven't gone together. And attempting to do that. Is there any sort of input of like what you think as far as like how things, what might make the local community happy if treatment looked a certain kind of way? Any perspective on that of like what maybe would check some of those boxes for people?
I think it goes back to the integration piece where, as long as we're not dividing that community and seeing them as like a whole different entity or community in itself, that's going to help aid some understanding in what treatment looks like, and really combat some of these like myths and things that we hear a lot. So just integrating the communities together and building that community within certain businesses and certain organizations, all of that stuff. That's really the only way that we're going to be able to alleviate some of that stigma.
And that's what it's based in, right?
Yeah, absolutely.
Like all those sort of like, well, we want it to look this way because then I'll feel better about it.
Right.
Is all based in like stigma, prejudice, preconceived notion, discrimination.
Yeah.
All those sort of negative things that I think that if you would confront a person about it, they would explain away why that's not it. But it's like that's what it's rooted in.
At the core, yeah.
And so you brought up another point that had me thinking. You were talking with the hollow fears of the behavioral health redesign, and how like us in the field were spooked about it, right? So then we're seeing this economic boom of behavioral health care providers in the region that are coming in, some of which you say, you know, you've talked about do good work, are good players in the community. It's the fears that you're talking about. A lot of those are hollow, you know. Follow the counseling center's page on Facebook, Misconception Monday. We've got our own sign guy, you know what I mean? And we like address some of those topics that we hear about, right?
Right.
Because we see those things within our social media. You know, one of our comments about that with the new main campus project, trying to increase our efficiency for better client care, that that there will be buses from out of state, bringing people to the area. And it's just not true. It's not the way reimbursement works.
Right.
It's not the way like quality behavioral health care works. It's not. It's like unfounded on so many different levels for that. It's just fear based, right?
And honestly, if we look at people that are coming in from a different city within Ohio, you know, a lot of those people that stay in treatment are contributing to the community in ways that are really powerful. And
absolutely,
you know, if they stay around, they build a life here. You know, they're passionate about whatever they choose to do, and they're becoming a part of the community. So I think that's also just a misconception too on that front, where like everyone's coming in and, you know, they're just like taking up all these resources and all of that stuff, and they're actually giving back, you know, arguably maybe more than some of the community members that are, you know, having a problem with this. So
yeah, absolutely. I always think about, you know, the agency and the treatment industry at large and our ability to like create jobs and those kind of things and employ people and keep people engaged in services at the same time that we employ, you know, those kind of things. Those dollars that this area works so hard for to pull down from the federal and the state level, every treatment dollar is the same, is a dollar that a smokestack isn't bringing in, that a factory isn't bringing in. Right. It's like, I don't believe that we are seen as an industry that provides anything other than problems. And I just don't think that's the whole story.